So you get the privilege of hanging out with me for yet another segment. I'm joined by Dr. Paixao, and we're excited to tell you about some new technology coming down the pipeline. In the same interest as I was mentioning in the case that you just witnessed, anatomical patient factors are becoming more and more of a challenge as patients are living longer and the disease processes are more complex. Treatment of these through minimally invasive techniques can be a challenge. And so we're going to tell you about a product now developed by a company called Biomodex out of Paris, France, that allows us actually to print 3D models structurally of certain parts of patient anatomy. And we're specifically going to show you some models that we employed and that we used here for teaching purposes of one of our fellows. And I actually have a case that's coming up in the next couple of weeks that's a complex anatomy involving a septum, where we've printed a model like this in order to help us plan for that case.
So it's a pretty interesting new technology, and it's brought to us by Gary Davis, who also interestingly brought the PQ bypass to our attention several years ago. We foresee this being used for training purposes. As Wes mentioned, one of the fellows that's training with us now performed his first sort of transeptal puncture practice with this model, but also in planning procedures. So sometimes it's pretty difficult to predict what size of device and whether or not the existing device will be a good fit for the patient's specific anatomy. So this kind of addresses that need. We get a CT here, and the data is sent to Paris, and in a pretty sophisticated procedure, they'll print these models. It takes them 3 days because it's in France, right? They work like 20 hours a week, but then they'll ship it back to us. So the model is designed to be of a similar echo density as human tissue. So on the screen here, you see a regular TEE machine, which is our own machine, and even though we're imaging the model, it looks like it's a patient's interatrial septum and heart. Dr. Lane has our transeptal puncture apparatus, same thing Dr. Rollinson used for that TAVR, and that's a sheath.
My sheath here, going up what would be the patient's inferior vena cava. We've got it through the model, and so this is the same sheath that we would use, and the same sheath that you just saw used actually in the prior case, in order to get across a septum. So within that sheath, you place a dilator and a needle, and you can see Dr. Paixao is inserting the needle behind me right now, and we're going to perform a transeptal puncture on this 3D printed model to look like an atrial septum.
And these cartridges are built on the patient's anatomy. That gray box is the sort of the support for it. It's fluid filled, so it looks like it's sort of blood, like a patient's heart and venous system. We're pointing to the interatrial septum. We're seeing the needle come down to our target area in the fossa ovalis.
And those of you who perform the procedure and who are familiar with echo will recognize that this is an extremely realistic looking echocardiogram. The only thing that's really missing is the real-time motion of the heart as it's beating. So with the fluid-filled space, you really do get the ability to train as close to an actual case as possible.
So you can plan not only the deployment of the device itself, but you can also plan the location of your transeptal puncture. In some instances, the success of your procedure will basically depend on that. The orientation of the Watchman device, which is a plug, will essentially depend on where you cross between the two atria. So by potentially attempting different crossing spots, you may improve your success rate for the procedure itself.
So one of the challenges of learning and teaching structural procedures is that you're taking 2D pictures and you're having to reconstruct those in your mind. So having a model printed and especially being able to practice on it really helps you to grasp what you're doing in the body. The procedure that we're practicing here is a Watchman deployment or a left atrial appendage occlusion. The left atrial appendage is a small little finger-like projection off the left atrium, a very posterior structure in the heart. You have to go across the intraatrial septum with our catheter, which is what you see here, and that was just an injection within the left atrial appendage.
So that's a very realistic injection. Let me go back here, because if I didn't know any better, I wouldn't say this is that patient. This is really reproducing really well what a true angiogram of a left atrial appendage would look like.
Agreed. And within the case, we would use this picture at that time to measure and size the prosthesis that we were going to implant. we already have a pretty good idea. Of course, these patients, the models that were built, they already have a CT scan, a CTA, so we know their anatomy already, and so a lot of the times we kind of have an idea of what size device, but if you have a patient with challenging anatomy, one of the benefits of having a 3D model is that you can really, if you have enough equipment, go ahead and try to deploy a device that you're worried might not fit and give it the road test, so to speak. So that's kind of what we're doing here.
So here you actually see the device itself. So it's attached to a catheter, so it hasn't been released. It's been fully expanded within the left atrial appendage, and now we are assessing its depth and orientation. We're using the echocardiogram and fluoroscopy. And again, this was very, very realistic. I was very positively surprised by how it felt in the cath lab.
Agreed.
That's a good position. We're injecting some dye there. There's still some flow of dye into the left atrium, which honestly happened in vivo as well. It takes the body a little bit of time to fully seal around it. And we inject it with high pressure. So this is actually a pretty good position for the device.
The Watchman device, you can see kind of right here. This is the end of my catheter, and what you just saw is we were untwisting and releasing the device, so it's been deployed within the model now.
And I think we go back to the echo. There we go.
Yeah.
And you see it's pretty flush with the ostium of the left atrial appendage, which is where you want it to be. And here's with the cartridge removed from the box, and you can see, which we never get to see this.
This is where it really becomes cool to play with.
Yeah.
You can see what it looks like in real time, what you just put into the anatomy that you're going to face. And so that's neat.
And now that Dr. Lane and I have got to play, we brought in the fellow and let him have a go. And then this is him sort of being trained to perform transeptal puncture. I mean, I wish I had this when I was training.
Yeah, and he did a great job. We got in, and you can see we did an angiogram on this one, a little bit of a different anatomy, a shorter appendage, one that you might be a little bit fearful to put a device in.
And this one will be a challenging case. I mean, this would be pretty useful to be able to rehearse ahead of time. You can try different angles on your angiogram, see which opens up better. And now we're using a second generation Watchman device. It's called the Watchman Flex. Unlike the first one you guys saw, this one has sort of a closed distal end. It doesn't have the pointy bits that we think gave us trouble.
So this is the fellow's first deployment of a Watchman. Andre, is that something that you'd leave in the body?
Nope, hell no.
So we're experimenting here. We actually used a Watchman that was drastically oversized to make a point. So this is about a 34, 35 millimeter device in an appendage that probably should take it about a 24.
And it's not supposed to have this shape. You see a big waist here, and a lot of that device is actually sitting outside the appendage and into the left atrium.
No.
So, I mean, this is not a patient that we have treated, but this, when the times come, it will be a challenging left atrial appendage occlusion procedure. We'll go in with a much smaller device, but it's a short appendage with limited depth.
Yep.
And on echo, you kind of see a big shoulder here. It's not supposed to look like that.
But good thing we have the opportunity to practice before we try it for real, right?
Yeah.
So as you can imagine, we're looking forward to the opportunities that are afforded by us to be able to see in 3D, to feel it, to touch it, to practice on it, to help treat patients, shorten procedure times, help us a little bit more confidently instruct patients on what would otherwise be challenging and a little bit questionable procedures. So if we can, I'd love to kind of pass this around with your permission. Gary, is that okay? To get your hands on it and touch it and see it. One of the devices actually has a Watchman device deployed in it, so you can turn it around and twist it and see. But any questions? The white part that's on the superior aspect here is the appendage, the same on the other one. You can kind of see the septum. One thing that I'll remark about is that it comes around. It actually is supposed to feel pretty similar to what the tissue would feel like. So we could get your fingers in it and touch it and see. It's really neat.
All right. Thank you, everybody.
Thanks, guys.